Hi, everybody. I'm Siobhan Sarna with SIBO SOS, and I am thrilled to have Dr. Norm Robillard with me today. So, hi. Dr. Robillard has been really generous with his time for supporting so many communities that have issues with their guts, including their, GERD. But of course, when it comes to SIBO, he's got a very special place in his heart and a technique and a diet that is very innovative, very revolutionary. And it's something that I've been wanting to talk to you about for a really long time, both to Dr. Robillard and to this community. He has a very important book that I think is essential reading. Even if you don't follow the exact techniques, it's going to make you think, and it's going to help you to understand what the fermentable load in your diet is doing to you and for you and against you when it comes to SIBO and IBS. So it's a warm welcome. I'm very glad you're here, sir. Thank you very much.
Thank you for having me.
So I'm just going to do a who, what, where, why, when, and how real quick. What is the name of your book?
Okay. Yep. And you have a little bit of feedback there too. We might have to adjust.
Okay.
I'm hearing you, but maybe it's just
you guys tell me if you're hearing an echo. Not sure what I can do about it right this second. Sometimes you may hear it at your place, but not.
If I can move my mic away from my computer, maybe it's coming through my speaker. That seems better. How's that at your end?
It's good.
Okay.
It's good. Okay.
So yes, I've written a few books, but two are the Fast Tract Digestion series. This one is on IBS, and it has a companion book on heartburn. And then we have developed the Fast Tract Diet mobile app too, which is getting a full facelift this year, and that should be out soon. So that's for Android and iTunes.
So the new app is, if you want to go ahead and sign up for the app once you hear Dr. Robillard talking, I think you're going to want to. And then when the new version comes out, you'll get an automatic free upgrade.
They will, yep. Mm-hmm.
Awesome. Okay.
Yep.
What is the premise of the Fast Tract Diet?
Well, it has a bit of an evolution to it. My own experience 15 years ago with chronic acid reflux. I had no idea what was causing it. I was taking all kinds of medicines and they weren't working. I was pretty sick with it. And I just happened to go on a low carbohydrate diet, which made a big improvement in my symptoms and just set me on this course to really understand why. And little did I know at that time that I was pretty quickly going to come up with a new theory about the underlying cause of acid reflux that had to do with malabsorption of carbohydrates, eating too many carbs, not digesting them well enough, feeding blooms of bacteria, and gas driving reflux. So at the time, that was a really novel idea. Nobody had really thought about bacteria and reflux. But over time, I realized that it was a very similar situation to IBS, and there was a lot of overlap between these conditions. And that's why I started focusing on those two, the connection with whether it's SIBO or libo or just excessive fermentation of some kind or dysbiosis. That's been the focus, and that's what led me to write these books, to set up a consultation program in this area. And, it's all I do now.
So what is the premise exactly of, there's some math involved. So how did you come up with this formula? And that's why I love your app so much, because it does all the math for me. But explain, if you would, that the science behind the formula.
Sure. Well, the first thing that I did beyond just a low carbohydrate diet made a big improvement. And it's still a great diet for people. Just cut carbs, you'll feel much better. That's for most people. But I really wanted to know which carbohydrates were the worst culprits. And so I started looking at, how fermentable all these different carbohydrates were, and also how difficult were they to digest. And so I came up with this handful, this groupings, fructose, lactose, resistant starch, fiber, sugar, alcohols, right? That was a list. Of course, some of those you can tease apart. Fiber's got a whole bunch of different types of molecules in it. So I had this list, but I thought, how can I make a diet out of this? Because who the heck is going to be able to pick up a peach and say, how much of those 5 things are in this? And I couldn't either. And I struggled with that for about 2 years. But I finally came up with an idea that I might be able to use the glycemic index, which for any food, they feed the food to 10 test subjects after a test run with glucose, that's the control. And then they feed those 10 people the test food, and they literally take blood samples every so many minutes, and they compare the area under the curve, how much blood sugar is entering your bloodstream from your gut, compare glucose to the test food. And that ratio is the glycemic index. So while that was used to measure how quickly carbohydrates go into the bloodstream, I realized that I could manipulate the equation and turn it around and modify it slightly to determine instead how many carbohydrates were persisting in the intestines. And of course, since fiber is not digestible, it's not really even part of the glycemic index. You have to add fiber and add sugar alcohols afterwards. So that's how I came up with the formula. And, initially I just put it into Excel and started cranking out a bunch of values for foods, and it just grew and grew and grew. And so it's in the, there's tables in the backs of the books, but we've really pursued it in the mobile app. In fact, this new release will have over 1,000 foods and these, what we call this fermentation potential, or FP value. And it's dependent on the serving size. And it's dependent on the nutritional facts. Anybody can do the calculation, come up with the same answer I did, but it's easier to just look it up in the app for most people. And that's how it happened.
So when our fermentable load is less, when we have SIBO and IBS, the whole reduction of bloating and symptoms is probable, right? That this is why we're doing it, right?
Yeah, I mean, there's no question in my mind that there's different sources of fermentable carbohydrates that bacteria can access, right? Food is a big one. These 5 different carbohydrates in the food, if they're not fully digested and absorbed, as most of them or many of them are not, they'll feed bacteria. And if you don't have SIBO, it's feeding bacteria in your large intestine, which might be okay for a lot of healthy people without gut problems. But if you have SIBO, or if you even have libo, and we'll be talking about that more in your upcoming thing we're going to tape. But if you have some kind of dysbiosis or SIBO, that these bacteria are kind of overgrown or out of balance, and they're very susceptible to having too much of this fermentable material. So diet is really a big source of that. But another source is mucus. The mucus that's produced in our gut and our small intestine and large intestine feeds, especially in the large intestine, feeds the microbes also. And it feeds them more when we don't feed them as much. Because remember, these microorganisms, they evolved in our gut. They're good for all kinds of things, short chain fatty acids, vitamins, but we really evolved with them as a survival advantage against starvation. So they process all of these fibers when we don't have, a lot of other foods, and they produce fats, and we get energy out of it. But if you're overfeeding the bacteria yourself with your diet, or if you have like an inflammatory condition and a lot of mucus, and there's all of these different mucin molecules, like 10 or 20 different types. And some have sulfur residues, and they have nitrogen, like amino acid type molecules, and 80% of the mucus is carbohydrate. So it's a good fuel source and a nitrogen source and even a sulfur source. It's a complete food source for bacteria. So if you had an inflammatory condition where you were producing a lot of mucus, maybe your gut was in the protective mode, you could be feeding these bacteria more in that way as well. And then also through your diet. So, it's all about giving the bacteria enough, but not too much of this fermentable material. Well,
let me ask you about mucus. Whenever I think, and then we've got questions from the Facebook community. Hi, everybody. Could a biofilm be involved in that mucus? Like, to me, when I think of mucus, I think of like, not just like mucus at my respiratory and in my mouth, but is it right to be thinking that goop that is the biofilm is mucus? Is that even close?
Absolutely. In fact, 90% of all these microbes, all these bacteria in the world, on the planet, exist in biofilms, right? So yes, biofilms along your mucus be, these well-adapted bacteria that evolved with us. They have specific binding sites on these, mucus layers, and it is a biofilm. There's biofilms on the fecal material as well. So you have all these biofilms, but I'm a little hesitant to just jump on the bandwagon that, I have a biofilm, I need to take something for it, because most of these biofilms are healthy and normal. And, some of this, bacterial turnover is just through being shed from the mucus layer in a normal, organized fashion. So there's a difference between biofilms and pathological biofilms. An early study of biofilms was done on things like wounds. They know that, when you had a staph infection and a cut on your hand, that they form biofilms there too, and it can make them less accessible to the antibiotics, for instance. And so it's hard to treat those infections. There's also biofilms for organisms like Pseudomonas aeruginosa in the lungs of cystic fibrosis patients, right? They have kind of an aberrant and too much mucus that's being released. That's the underlying genetic problem. So some of these biofilms, we need to do something about them. Other ones we don't. And when it comes to the gut, I think we just don't really know well enough, with one exception. There's been some very good work on colon cancer showing that it does involve a mixed biofilm of bacteria, but it's a very invasive biofilm that goes beyond the mucus and into the cellular layers. And there's some very good work going on. Ruth, and I forget her last name at the moment, but I saw her speak at the American Society for Micromeeting last year in Boston. Just phenomenal work. And so there are some of these that are bad, and some of them are probably not so bad.
Okay, I can live with that. All right, good. Now I hear feedback. How does that happen? Nothing changed.
Oh.
Do you hear feedback?
No.
Okay, I
did at the beginning, but not now.
Okay, I'm just going to keep going. So let's get to the questions from folks in the SIBO community, SIBO SOS community. Okay, hey Sharon, I have SIBO and colitis. Please share diet solutions that relate to having both of these conditions. Foods okay with SIBO are not usually okay with colitis. And also Carolina has that same question.
Yeah, that's a big question. And by the way, it's a good time for me to say that, even though I'm a microbiologist, I'm a consultant, I consult with clients. I'm not diagnosing or treating any disease today. People need to talk to their own doctors for that. So we're just having a discussion about some of these topics. And so those are two very different things. So one is some form of colitis. And what was the other one? Was it SIBO?
Yes, she has SIBO and colitis.
SIBO and colitis, yeah. So, SIBO, we're going to be talking a lot about that. And sure, I advocate 3 approaches for that, right? A 3-part approach. And that's what this book covers. Limit fermentable carbohydrates, all about diet and digestion. The second one is identify and address potential underlying causes, right? That's where the colitis would fall, right? So you've got SIBO, you're working on the diet, you're looking at these underlying causes. Colitis is one of the things you might be looking at. And the third part is behaviors and practices. The better you can optimize your digestion, and there's a lot of things you can do there, you can, again, reduce the amount of malabsorption and not overfeed these bacteria. So, and Carol, right, on the colitis, I would immediately want to know, say I was working with you and we were trying to generate some ideas for you to follow up with your doctor on. I'd want to know an awful lot more. What were the tests done that were, did you have CT scans, colonoscopy, endoscopies, all of the different tests you had, and what type of colitis it was. Is it microscopic colitis? Is it collagenous colitis? Is it Crohn's disease? Is it ulcerative colitis? So I'd really want to know a whole lot more. Because Crohn's disease, for instance, does often result in SIBO, right? Because you can get scarring, ulceration, you can get narrowing of the intestines, and all of that is going to slow motility and back things up and can lead to SIBO. So people with Crohn's often have SIBO, and so reducing the fermentable carbohydrates is important for Crohn's, but it's got genetic underpinnings, imbalances of bacteria, because how the bacteria interact with your own gut and your immune system is kind of off a little bit in Crohn's. So there are, some people that believe that you've got to be careful with too much meat on a Crohn's diet and so forth, but at least the SIBO part of it, you would really need to watch the fermentable carbohydrates, whatever else you did. So, that's a question. It's deeper than in scope than what we can really cover here.
When she's talking about how SIBO diet doesn't work for colitis diet, what's the conflict there?
Yeah. Well, for instance, if it was ulcerative colitis, that is a large bowel disorder. It is also an inflammatory bowel disease like Crohn's, but it's a disorder limited to the large bowel. And so, like, for instance, removing the large bowel is curative of ulcerative colitis. It doesn't have the same connection with SIBO and this type of diet. And I know that because I've read some of the studies looking at using things like elemental diet for ulcerative colitis. And there may be some other examples where very low carbohydrate diets were used for UC, ulcerative colitis, and they haven't been effective. Anecdotally, there are people with ulcerative colitis that do think that diets like these, specific carb diet, low carb diets may be helpful, but in the scientific literature, it's not helpful. So that's one difference. With Crohn's, you do see improvement in Crohn's in terms of the symptoms and remaining in remission on something like the elemental diet. So the elemental diet is a good one to use if you're searching the literature for some of these serious conditions to say, okay, does a diet that really restricts the fermentable carbs, and an elemental diet has a lot of glucose in it, but that's rapidly absorbed for most people. So consider it like a low fermentable carb diet, one of the best ones actually. And so if you can look at these conditions and see whether elemental diet helped or not, I think that's a good inkling whether this larger family of diets would be helpful in that case. So for Crohn's, yes. For ulcerative colitis, not so much. And then for these other, microscopic colitis, there's other approaches that may be important there too. Budesonide is one of the drug families that's been used for that. But again, talk to your doctor. We're just talking some science here.
Yeah, exactly. Okay.
Thanks for the question, though. Very good.
Yeah, we wish you well. Devanshi, I don't think I'm half Indian, so I should be pronouncing this properly, but I don't think I just did, so pardon me. A vegetarian sample food plan to start Fast Track. Got the book, but no sample vegetarian plan. Well, I'm a vegetarian too, Norm, so what can we do, sir?
Yeah, that is challenging. It is something that I do work on. I spend some time on that because I've worked with some people in this situation. Let's face it, where does most fermentable material come from? Plants, right? And especially the higher carb or starchy plants or fibrous plants, so corn and some of the rices. Some rice isn't so bad, unless you have a particular problem with digesting starch, that even the easy to digest or what we call the amylopectin starch might give you a little bit of troubles. So some people can use like jasmine rice. That gets a lot of play on the Facebook pages these days. That's something I came up with because it was one of the ones that has a high glycemic index, so a low FP. That's why it's in the book and the app is one of the safer starches. Some people still have to watch that on the front end. But there are things vegetarians can do. Most vegetables, if you look, I don't have the app in my hand, but if you looked at the mobile app and you looked at these vegetable tables, some 150 vegetables, maybe even more now, and then a whole variety of fresh herbs. Most of those on the list are pretty low in these FP points. Green leafy vegetables, that's the example a lot of people use, but then most vegetables aren't too high. They do gradually start to become higher in points, higher in starches. When you get to the butternut squash, and then you get to some of the potatoes and the rices, you are getting a little more starchy and more more carbohydrate and more FP points. But fresh herbs, lots of green vegetables, they're an option on a vegetarian diet. Another one, if you don't have a big issue with some soy products, tofu is very low in carb and low in FP. And so somebody wrote a review for, it was either I think it might have been the heartburn book on Amazon. I think he goes by the name Chaz. That's his screen name on there. But he wrote a long review, and he's a vegetarian, and he has had success. But he uses a lot of different soy-based products in that. Not everybody's comfortable with that, but for him, it's worked, and at least to the point where he can really get his symptoms under control. So you could read that review. You can go to the Fast Tract Diet Facebook page and just search it, because there are vegetarians on there, and so there are a lot of posts dealing with that.
Okay, there's a start for you. I'm going to keep you moving because we got a lot of questions coming in. Oh, by the way, we are doing a masterclass in Q&A with Dr. Robillard, and that is in January. And he and I are taping the class this weekend. And then what will happen is, if you decide to purchase the January class pass, where you'll get Dr. Gervich's, Dr. Robillard's, and the Q&A from Dr. Seebecker, you'll get instant access to the course from Dr. Robillard. And then on January 26th, I'm going to replay it. And then he's going to come on and answer Q&As for 2 hours. So look for emails from us on that. And I think Mariel's with me today on the Facebook group, and she can post a link if you want to find out more. Okay, what I have for you now is, I often get acid reflux, such as a cough or throat clearing about an hour and a half after each meal.
Speak up just a little bit, Siobhan.
Yeah, I often get acid reflux, such as a cough or throat clearing about an hour and a half after each meal. Do you think where acid is from, 1.5 hours is not long enough for fermentation yet, correct?
No, not always. It's a good question, though. So, the coughing and the throat clearing, it's considered one of the, LPR type symptoms, laryngopharyngeal reflux. Unless you have a cold or an allergy, there are other things that can cause that as well. But if it is LPR, it's a chronic type thing. It is, most people, ENTs and most doctors, they'll agree, if they're in the know about it, that it does look like these things are reflux related. Same with asthma. 80% of kids with asthma have chronic acid reflux. So there's a connection there. But how fast can you expect this thing to happen? And it depends on your digestion, but also the type of carbohydrate. For instance, lactose. If you're lactose intolerant and you won't break down lactose, it's a simple 2-carbon sugar. But if you can't break that bond in the middle, if you don't have lactase, it's a genetic thing, then it goes into your small intestine. If you have bacteria kicking around there, they love lactose and they can ferment it very, very quickly. So if they're already growing, if you give a little food source to a small number of bacteria, and then they have to multiply and multiply and multiply, it can take overnight. You start with a small number. But if you already have a decent population of bacteria there, now it's just like a machine. It's an eating machine. You give it this lactose and it just gobbles it up and produces a lot of short chain fatty acids, enzymes, and maybe even toxins, but gas. And so this gas could translate into some reflux, I would imagine, pretty quickly. More complex carbs, some, cellulose is probably one of the toughest starches. Methyl cellulose, that's something you get in a supplement. They're very tough. It takes a lot of bacteria collaboratively, a lot of time to break it down. So it might be 12, 15 hours before it finally gets broken down and you get some of that gas. But polymers of fructose, right? Fructose oligosaccharide, inulin, even fructose itself, those can be broken down faster by bacteria. So an hour and a half, I would expect you could get a good bit of gas. I would even say you could have the symptoms from lactose within 20 or 30 minutes in some cases. So is the gas production then opening up the lower esophageal sphincter, and that's what's causing the acid reflux? Is that the right thinking? Well, that is the theory that I proposed. And there's a lot of evidence for it in the books, first of all. But more importantly, the diet is being studied, and it is being studied in places where they're going to include breath testing. I can't say more about that stuff yet, but we're trying to get at that question in terms of actually having some data and publishing it, whether or not I'm right. And I think I'm right, but need to prove it.
Okay. Well, you have a lot of anecdotal evidence. Okay.
Not even anecdotal, scientific evidence, studies.
No. But already so many people are getting such great results.
Well, that too. But I mean, in the books, there's actual, yeah. Like, for instance, with acid. Sorry?
What are you still trying to prove?
Well, it's proved in terms of scientific reasoning. Like, for instance, there was a study in the 90s, if you take people with GERD, people with chronic heartburn, acid reflux, and you give them a prebiotic, in this case, they gave them fructose oligosaccharide, right? One of the ones we were just talking about, little chains of fructose. It's a dietary fiber. It's quickly fermented. When you give it to people with reflux, it's well established. This paper was published, over 20 years ago. And they not only have worse symptoms immediately, but they literally have worse reflux because they had probes down there measuring it. So that's just one example of the kind of science you can look at to say, okay, well, if this theory is right, what can we expect? What would disprove it and what would prove it? And I spent a lot of time on that when I first started working on this theory. And so I think it's right. But now we need to actually take the approach and have the breath testing and have the the reflex measurements with this particular diet, and we're working on that.
Very cool. Okay. I don't have this person's name at the moment, but her hubby poops out undigested food within an hour of eating it. Why is he not absorbing his food, and why does he poop it out so soon after eating?
I apologize, but you're gonna have to repeat that one more time, and let me turn up my speaker a little bit.
No problem. And I know there's a bit of an echo, or I hear it anyway. We're just going to keep going. Her husband poops out undigested food. And why does he poop it out so soon after eating? Oh,
okay. Okay. Yeah. Poo question. So first of all, is he in a state where he's having diarrhea? That's one question. Because there's all these different causes of diarrhea. Of course, SIBO itself can cause it. Just too much of some of these fermentable carbohydrates, even themselves, right? FODMAPs and stuff that can cause, water to come in to be retained in the intestines. But SIBO and all the issues they cause, the whole thing with the cytolethal distending toxin, of course, that's a pathological thing when you get a GI infection. All these things can cause diarrhea. Bile malabsorption can cause diarrhea. You're not reabsorbing enough of the bile. Your liver produces bile. It's stored in the gallbladder. It's released with a meal, especially a fatty meal, right? But in the ileum, the lower part of your small intestine, over 90% or 95% of that bile gets reabsorbed, goes back to the liver, because it's an expensive molecule for the body, right? It conserves it because cholesterol is not that easy to make in the body. So it gets recycled back. But even if more than a few percent of that bile reaches the large intestine, that will cause diarrhea. And they call it BAM, bile acid malabsorption. So if you are having diarrhea, it's not surprising that the food isn't being digested fully. So I would say that, if I was working with this person, I'd really be focused on understanding and getting to the bottom of what's the cause of it. And poor digestion is potentially a cause of it, because you could have too many of these carbohydrates. But we'd have to look at the whole thing and look at, again, we try restricting the fermentable carbs. We'd also spend some time on the underlying causes, and then we'd look at the behaviors. Is he eating slowly and chewing well? All of these different things that go into optimizing digestion. Good question, though.
Yeah, and she said that he basically loose poop and sometimes diarrhea. I'm going to keep going. I hope that helped. Is he chewing slowly and all that? That sounds super simple, but It shouldn't be overlooked. Okay, Anna, can the Fast Tract Diet plus herbals resolve SIBO? She has SIBO, but doesn't know the underlying cause, as I have no other digestive issues related. I can only think about dysbiosis that led me to SIBO. It's nearly 2 years. I'm treating my SIBO with antibiotics and herbs, but SIBO test always comes back positive. So can Fast Tract Diet plus herbals resolve SIBO, Norm? And I guess the other thing is the Fast Tract Diet enough?
Yeah. Well, the point I made earlier, somewhere along the line, I ended up being being cast as the great defender that diet alone is enough. And I hear that all the time. But I've never really said that, because with the Fast Tract Diet, it's those 3 pieces. You can't leave one of the pieces out: the diet, underlying causes, and behaviors. So that's what I would say first. Everything else, I think, comes after those 3, because in my mind, and this is just my approach, we all have our own experiences and biases, and we read the literature in a certain way. I feel like those are the most holistic, the safest, kind of paleo, if you would, living in balance, and not, we're in a society where we just have access to so much food, so much snack food and junk food, that I think that's part of the problem. It's overnutrition, but instead of overnutrition of our bodies with obesity, it's overnutrition of our microbes. So I think that's one of the big issues. So where do herbals fall in this? I've spoken a lot about antibiotics because I used to work on them. I've studied, transposons and genetic elements that confer antibiotic resistance. I've studied gene transfer between gut bacteria. When I was at Tufts, I worked on the development of Cipro at Bayer. I've studied the antibiotic resistance and the genes, and what goes wrong. What's the gene for DNA gyrase, and why is that involved with Cipro resistant? And I've looked at the stuff for years and years, and I know that all antibiotics, I've studied just a whole variety of these. They're either synthetic, they're made in the lab, but back in the day, they used to come from bacteria and fungi and plants, right? So your herbals are in there somewhere, and all antibiotics have a certain number and type of strains that they inhibit or kill. They can be cidal or just inhibitory. They all have a certain potency, and they all have a certain pharmacokinetics. So when you put things in your gut, if it's absorbed into your bloodstream, it's not too good. But a lot of these herbals, like rifaximin, maybe they stay in the gut. There is some data that they will knock down the number of bacteria, which can be, in some cases, a good thing. And rifaximin as well, rifaximin and neo from methanogens, possibility. Not my first go-to thing, because they're not just knocking down the ones that are causing the problem. That's the real thing. It's a bit of a shotgun approach. They're going to knock down other strains too. And so if you inhibit or kill the good guys, that can put you at a little bit of a disadvantage. So believe me, I've worked on antibiotics. I do think they can be downright life-saving, and they can be important in some instances too for these gut issues. But I really do think diet and holistic behaviors is the first thing you should try. Herbals in general, probably a little better tolerated than some of the others, than some of the real hardcore Cipro and some of the real powerful synthetic antibiotics. But, some people do complain, stomach problems from, berberine or olive leaf oils and all of these things. It's just not my first tier treatment. I can understand if it's working for her, but long-term, it's those 3. That's what I believe.
Okay. How might insulin resistance affect digestion and fermentation? That's a good one.
Well, yeah, it is a good question. It encompasses a lot. So when you have insulin resistance, right, first of all, why? You have some kind of metabolic disorder, you have prediabetes or diabetes. And what are the causes of that? Well, mostly it's a cause of high blood sugar, chronic high blood pressure, right? Type 2 diabetes, you're insulin resistant. And so after a while, your pancreas keeps making more and more insulin, but it's still not enough to clean up the blood sugar in your bloodstream because you're insensitive to it. And then finally, the pancreas islet cells wear out and you don't even have enough insulin to get rid of all the blood sugar. And that's when you have diabetes, you have high blood sugar. So in a way, both the issue with SIBO and dysbiosis and libo and excessive fermentation of the gut, there are some similarities between that and a situation where you have high blood sugar, right? It's carbohydrate toxicity, right? And in a way, you would be better off, in my view. Some people have different approaches and different ideas, but in my view, in both cases, you're better off on a lower carbohydrate diet. Because with low carb, just for blood sugar, right, you're going to have less glucose pouring into your bloodstream. You're going to be less dependent on insulin. So if you're insulin resistant and your insulin isn't working so good anyway, I'd say less blood sugar, because then your liver will take over through gluconeogenesis, producing the blood sugar in a more regulated fashion. And so I would think you'd be better off. It's the same with the gut, I think. Back in the day, it was really hard to find all these high carb, vegetables and starches and stuff when we were running around in the woods 10,000 years ago. We didn't have all the grains. So we didn't consume as many carbohydrates, I don't think. And then what happened? Just like the analogy when the liver produces the glucose when you eat less carbs for your bloodstream, the mucus is going to produce more of the glucose for the bugs in your gut. And again, in a more regulated fashion. So for that question, I think the answer is the same for both. A lower carb diet would be my first go-to recommendation.
Okay.
But again, understanding why have you become insulin resistant?
Okay. While doing microbial treatment, I think she means like a treatment when she's doing like antibiotics or herbal. Should I eat regularly to bring bacteria out or do low FODMAP? I did herbal treatment, berberine and oregano, ginger, turmeric combo for 3 months, and S. Boulardii for a month. Strict low FODMAP. Felt somewhat better, but still positive when tested. I'm off of everything now just to see what my body feels like. Not great. I have hydrogen with hard stools. Xifaxan not covered on Medicare without diarrhea. I want to start herbals again and want to know what I should eat at the different stages of treatment.
Yeah. So again, I'm in territory that I'm, not, it's not my preferred starting place, jumping right into the antimicrobials. But I did write a blog on this very question on digestivehealthinstitute.org. So it might be myths for SIBO treatments, something like that, but you can find it on there. And I did address this question because there is this belief and some evidence that well-fed bacteria are easier to kill, right? And that's what the whole thing is based on. So when you go on one of these antibiotics, whichever type it is, there's this idea that if you eat more carbohydrates, plus it gives you a chance to just indulge, I guess, that you'll be, your treatment will work better. So that's one perspective. And there is some evidence for it, but it does vary depending on the type of antibiotics, whether it's rifaximin or Cipro or other antibiotics, and what types of bacteria are involved. So it's not just for everything. And there's an other side to this coin. And this was shown very well in a paper by Justin Sonnenberg out at Stanford. And he does a lot of work with mouse models, but I think it's very applicable because basically what he was showing is that when, what a lot of people have been worried about, right, is when people get treated with antibiotics, right? We had one of these questions about that before. Do I have a risk of C. diff, right? And for most antibiotics, you do have a significant, increased risk of having a super infection with Clostridium difficile. Well, why is that? Well, he made a good case of a scenario that would support this risk and why maybe having more carbs when you're taking an antibiotic is not a great idea. And here's what it is. When you take an antibiotic, you are inhibiting or killing a whole wide range of bacteria in your gut, right? And what are those bacteria typically doing? Consuming all of these carbohydrates. And so when you kill or inhibit them, now you have a lot of excess carbohydrates there. right? And you have all of these, sialic acid and other mucus residues of carbohydrates there too. So all of this unburned fuel. And then in comes C. diff, and it's got free food, not a lot of competition. And that he actually showed in his models that there was an increased susceptibility. I'm not sure if he used C. diff. I know he used salmonella, maybe a couple of other pathogens, but saw that this played out. And so in that scenario, the last thing you would want to do is throw more fuel on the fire. So there's two views on that. I would say you're better off without adding a bunch of fermentable carbohydrates when you're on an antibiotic, based on my reading of the studies.
From Amy. What should I look for on a breath test to rule out or diagnose libo?
Oh, so I've been talking about libo. All of a sudden now people ask me, okay, what do I do about it? Yeah, that's a good question. How to rule out libo? Well, it's still, I don't want to call it just theoretical, because there is some data suggesting that libo could be a factor. And in fact, back in the day, decades ago, when you talked about carbohydrate intolerance, you were mostly referring to excess fermentation in the large bowel. The only time people talked about SIBO, they used to call it SBBO, small bowel bacterial overgrowth, was when surgeons made a mistake and there was a kink in the intestines and the bacteria backed up. But once Pimentel and others started doing more work on IBS and SIBO and found out it's involved in all these different things, more studies, and so more people became focused on it. But I almost think what happened is we started thinking so much about SIBO, that me included, it's in my book, I write a lot about SIBO in my last two books, that we started to forget a little bit about just excess fermentation, which could be the small bowel and the large bowel. And a couple of studies, and Siobhan, you and I have talked about this before, came to light. Probably had too much detail before, but let's keep it simple this time. A couple of studies highlighted this possibility. And one was a study that used a radioactive probe or tracer during a lactulose breath test that showed that by the time a lot of people in the study received a positive diagnosis of SIBO, in which case the lactulose should have been getting fermented in the small intestine, the hydrogen diffusing to the lungs, and in the breath in the tube that detected it. By the time they said, okay, within 90 minutes, yes, you produced a lot of hydrogen, you must have SIBO. In this study, they were saying in those instances, the probe showed that the lactulose was already reaching the large bowel, and what they were really measuring was rapid transit. And so that fermentation, if it was excessive, would have been more of a libo. Now, some of the lactulose would still be in the small intestine, so I've made a case that you probably have libo and SIBO. And the other one, just to quickly touch on that, was using smart pill technology. Swallowed a smart pill that could measure the pH, the acidity, and they found that with people with IBS, they didn't have much acidity in their small bowel, but they did have more acidity in the early part of the large bowel. And acidity is indicative of excess fermentation, right? Because when these bacteria ferment carbohydrates, what are they producing? Short chain fatty what? Acids, right? And that's what makes the pH go down. So that smart pill, they made a case that people with IBS, they probably have, at least in their patient population, have more fermentation in the early part of the large intestine. So there is no commercially available test that I know of for that right now, unless you go into one of these research labs and said, give me the smart pill. I want the smart pill. But I don't think it matters that much for my approach, for the Fast Tract Diet approach, because you're limiting fermentable material. It doesn't matter whether they're in the small bowel or the large bowel. You're limiting the amount of fermentable material. It should work great for both of those. And this approach, it's a durable response. They've showed it with lactose and fructose and other individual carbohydrates, that if you're lactose intolerant and you avoid lactose, you can do it for 5 years and your symptoms are improved. There's no resistance or anything. Now, if you did have libo, you could fail on a rifaximin treatment, because rifaximin According to the scientific literature on rifaximin, it's most active in the small bowel because it's important that it has bile to facilitate its activity. And as we mentioned, most bile is absorbed before you get to the large intestine, so the rifaximin will not be active in the large bowel. So you can look at it as a good thing. Well, it won't disturb my other large bowel strains, but also if you had libo, might not be a good choice. So I'm sorry, I don't have an answer to firmly diagnose that, but focus on diet and behaviors, and it should help that as well if you think you have that.
Okay. Echo is killing me. One more. I have Nancy. I have a methanogen bloom. I finished the 3-week course of Xifaxan and neomycin 2 weeks ago, and now have my hydrogen breath test kit for retesting. When to retest? It says stop antimicrobials and wait 2 weeks after enema. Background, I get regular colon hydrotherapy and start taking allicin soon after completing the pharmaceuticals. While on treatment, my skin cleared. My global pain decreased dramatically. My happiness increased, yay, and my food tolerance increased. My constipation remained, and I ate carefully to avoid the pain of gas production. In the past 2 weeks, my symptoms are returning. I've ordered more medicine, but it's several weeks out. I do not seem to tolerate Atrantil or ginger well. So Dr. Seebecker has very specific advice about when she suggests retesting. Do you want me to do that right now, Dr. Robillard? Can I just say that real quick?
Absolutely, yeah.
She just says to retest, don't worry about having just taken the treatment. That is the perfect time to retest. And if in the recent Q&A that we just did with her, she talked about how she has asked the breath testing labs over and over and multiple times again to adjust their literature. But for retesting, you don't need to wait, and you just need to test it quite quickly after the treatment is over so you can determine, was it SIBO or wasn't it?
Sure.
And that is
test
very
quickly.
important.
Test quickly before it comes back. No.
Yeah.
And it does sound like a lot of some efficacious ideas. So rifaximin and neo is the combination. Allicin, it seems to have some activity there. But this, the Methane, Brevibacter, Smithii, these archaea are very tough. They're very antibiotic resistant. They've looked at populations that people that had high methane levels in these organisms, retested them 30 years later or over 30 years later, and they still had the same population despite being on a number of different antibiotics and so forth. So while there are ways to impact it, it is very hardy and stable. I did work with one person, and it's N of 1, of course, you need studies for all of this stuff, but he had very high hydrogen and methane and constipation. And after working together for some time, he did get retested, and his hydrogen was gone. His methane levels were cut in half. Now, that's anecdotal. It's one person. We need better studies. But it did seem to align with the concept of if you can restrict fermentable carbohydrates enough, and therefore you don't have that much hydrogen production, and that's one of the things that feeds into making methane, right? It's the fuel for methane. And so it makes sense that if you can diligently restrict fermentable carbohydrates, you might also be able to bring down methane. So I'm not saying the other approaches aren't valid or either, but and Allison said when to retest, and that makes sense to me. So I don't have any more comments on that.
What do you think about gluten?
About what?
Gluten.
Gluten. Ah, okay. I don't eat much gluten myself. In fact, before this webinar, I had a cloud bread and peanut butter and low carb jelly sandwich. So that's my version of bread. I love it. I don't eat much gluten.
What's your version of bread?
Cloud bread.
I don't know what that is. What's that?
Oh, well, you make it with. It's basically eggs and cream cheese, but you whip the egg whites separately until they're real thick like a meringue. And then you add the cream cheese, 1 ounce of cream cheese for every egg. So I'll basically do 8 eggs at a time in a whole package of cream cheese. and you blend the egg yolks up with the cream cheese, and then you fold those together kind of gently till it looks like clouds. And you put it on a baking sheet, with some wax paper under it, and you bake it at 300 for 30 minutes, and it's just great. It keeps for about 4 or 5 days, and it's a delicious bread replacement.
Oh, well,
yeah,
I am into that. Okay.
Good. So getting back to gluten. Gluten is it's a huge topic. I mean, for people that are genetically susceptible, not all of them will get celiac disease, but people that have HLA, DQ1, DQ2, there's certain genetic types on these white blood cell surface molecules that depict people that are most likely to be susceptible to celiac disease. But still, a lot of them never get it. So 1 or 2% of the population has it. When you do have this reaction, it is considered an autoimmune reaction against these gliadin parts of the gluten molecule that are very tough and don't get digested, get into the system, generate an immune response, and then that cross-reacts with a number of different enzymes and molecules and damages the villi in your small intestine. You get this severe villus blunting. So that's what's going on there. Now, if you don't have celiac disease, do you need to avoid gluten? I think maybe that's what the question is. So people with celiac disease do, but even people with celiac disease that avoid gluten, even when they're very diligent about it, a lot of them, somewhere between 30 and 70%, still have problems. So even on a gluten-free diet, a lot of people are still not completely well. And it makes me wonder, I know the one group looked at FODMAPs, and they thought that some of these FODMAP molecules in wheat might be the problem instead of gluten, which was a couple of interesting papers. But there's only about 2 to 3% of those FODMAPs in, say, wheat. But what else is in wheat? Well, 26%, up to 26% resistant starch. So I think this wheat also has a lot of resistant starch, and that could also be a problem. And then for people that have gluten sensitivity, but they're not celiacs, they may be reacting to this resistant starch as well. So I'd say keep your FP low and lose the wheat. And if you did have wheat or other grains, try to choose some of the ones that are lower FP. There are some of those that are a little easier to digest.
And FP stands for somebody who's new?
Fermentation potential. Yeah, it's that calculation.
Okay. So guys, check out the Fast Tract Diet app, check out the book on Amazon, and join us for a masterclass and Q&A session with Dr. Robillard. There's a class pass I put together, so everything that we're going to do in January you can get for a discount, or you can pick up things separately. And there's a link, if you go to the discussion right there, there's a link that you can click on and find out more about it. But he and I are going to tape the class this weekend, and then we're going to release it on January 26th. So this weekend, he and I are going to do the recording itself.
I better get to work.
Yeah, you better get to work. Later on in the week of next week, if you want to pick up the class pass, you can do it right now, of course. But what will happen is I'm going to send you the content in advance along with the slide deck. So that on January 26th, I'm going to replay it in case you missed it or just want to refresh or hang out with me during the hour, where I'm replaying the video. And then from 4 to 6, that'll be at 3 p.m. Eastern, 4 to 6 p.m. Eastern, Dr. Robillard is going to come and answer your questions. It's a new format for us, but I thought, wouldn't it be cool if everyone had the material in advance so that when we get together for the Q&A, it can be even more a richer experience for you. So this is our trial month. I hope it works. I think it's a cool idea. I hope you guys like it. And if you want to buy it separately, you can, but we are trying to get everybody to get on board with a pass because the discount is so big. And you'll also get Dr. C. Becker's Q&A, and you'll also get Dr. Alana Gervich's 2 masterclass mini-series. So it's all at the link. It's explained there. Dr. Robillard, thank you so much. I'm going to talk to you this weekend when you and I do the recording together. And this was very illuminating, and I can't wait to learn more and share your information with everybody.
Yeah. Thank you for having me, and thanks for the great questions. I appreciate hearing all these questions myself. Makes me think.
Yeah, this group is so smart. So smart. Okay, we'll talk soon, you guys. Thanks so much.
Bye.
Bye-bye. Bye.